The next panelist is Duanne Pearson. Duanne Pearson is currently with Premier Inc., and he is here to give his very unique insight on this issue. Thank you.
Thank you. Thank you for having me here today to talk on this issue. So Premier is a collaborative of 3,900 hospitals nationwide. So our members come together to improve healthcare outcomes, change the way we're delivering healthcare, and how we pay for healthcare in the future, in the sense through that care coordination and improving quality outcomes. One of the biggest issues for us and how we got really into this effort of how we address the opioid crisis is Premier has a large accountable care organization collaborative, so otherwise known as ACOs. So ACOs are networks of hospitals, physician groups, and others who take on the risk of taking care of the patient population in their communities. And so they enter into agreements with Medicare or Medicaid in order to basically have an opportunity to take less upfront on the reimbursements for opportunity to possibly engage in shared savings with Medicare or Medicaid at the end by helping improve outcomes and cost savings for the government. What we found is that in 2013, we actually had our ACO, we got our first information, which is when we enter into it, we got claims data to understand the issue. And as we worked through this issue over the years, we're discovering more and more that we weren't getting any information on the sense of how to help those suffering from addiction. And so as we dug into this issue, we were going through the process, which became a very complicated issue, is that there are two privacy laws that govern healthcare in this country. One, probably everyone in the room will probably recognize, is HIPAA. HIPAA is the gold standard, passed in 1996. It covers every disease and condition with the exception of addiction. So alcohol and drug addiction aren't covered by HIPAA. So for providers in the healthcare community, whether you have HIV/AIDS, STDs, Hep C, cancer, to diabetes, or whatever your condition is, we can coordinate and share the medical record in order to do the full care continuum and treat the patient as a whole. When it comes to addiction, the challenge lies with a law known as 42 CFR Part 2. It was passed in 1972. The reason for the law was, at the time, it was at the beginning of the war on drugs. In some cases, certain methadone clinics were being raided, and the paper medical records, which were at the time paper medical records, most people are moving to electronic health records today, were being seized and used in criminal prosecution. So the law that went into place with 42 CFR Part 2 is 373 words long. And what it does is it protects the patient from criminal prosecution, allows them to seek treatment in a safe process, but it also puts them in control of their medical record, in which they have to get consent for a physician or a hospital to see their medical record. Flash forward to 1996, we passed HIPAA. We're allowed to share medical records for everyone, and today we still have that law Part 2, and the challenge we're having as we move into the 21st, as we're in the 21st century and we move forward in healthcare delivery, is the patients as they present in emergency departments, we don't have a full capable understanding of their conditions, because the challenge really is that the electronic health record doesn't capture the addiction record. And most addiction providers, you know, they're going to be keeping a paper record. So as we deal with this population, and the challenges we have with it is that, as the doctor had mentioned, there's a lot of complications with buprenorphine, and there's a lot of contraindications in the sense of what drugs might contraindicate with it. And as we try to help people get off of whether it be prescription opioids or heroin and other items, we have to be very mindful of patient safety and care coordination, and those aren't possible now if we can't see the full medical record. And so we've been working with Mr. Mullen and Mr. Blumenauer on a bill to align Part 2 with HIPAA so we can share the medical records. And so you might think, well, what does that do for the workforce? What does it do for health? Well, if you look at it, if we're not coordinating care, if we're not able to do the warm handoffs for the emergency department, we can't get people to community services. If people can't get into community services or the treatment areas, they're not going to get the help they fully need. And it makes it harder to treat them back home. It makes it harder for the providers when they see that one individual who's a frequent flyer of the emergency department coming up to 15 to 20 times for an addiction or for overdoses. And it's really putting a burden on the system to where in which, how do we help these patients? So we've been advocating to align Part 2 with HIPAA, the HR 5795, which is moving to the House floor, and we thank Mr. Mullen and Mr. Blumenauer for their support on this. But it really is playing a part in the sense of how do we do care coordination down the road if we don't change this. We can't do telemedicine safely if the provider who could be 200 miles away from the patient can't see the full medical record. And what if that patient doesn't have a hospital near them? They don't have an emergency department near them if they have an adverse event. How do we prevent, that issue? How do we do, medication reconciliation safely if we can't see the full medical record? And, how do we change the way we do healthcare and make sure, as we change the way we pay for healthcare, if the provider can't really understand the patient and to help them in that, would help the government really and others in the sense of getting costs down and better outcomes. So those are some of the big conditions from Premier and the healthcare community's aspect is we need to make some changes to an old law that'll help us to do care coordination and improve patient safety. I'm happy to answer some questions a little bit later.
Thank you so much, Duanne.